twice as many DVTs as with the rivaroxaban. Okay, if you now look at the subgroup analysis, and I want to point, there are no major differences. Well, unless you come down here on the duration of the intended treatment, 3 months, 6 months, or 12 months, the major difference in favor of continuing treatment with rivaroxaban is with 12 months. So if you're going to give it for prolonging the benefit, you should give it for 12 months. Now, the principal safety outcome analysis is shown here, and there is no real difference in any of the bleeding observations. So the conclusion is that oral rivaroxaban, initially for 3 weeks as 50 milligrams, followed by 20 milligrams daily, will provide an effective treatment for DVT. And now we come to the Einstein extension study. In this study, rivaroxaban was compared with placebo after the patients had completed their treatment with conventional therapy. And of course, the results, as we would expect, would be much better when they were treated than when they were not treated. And we now have a measure of the efficacy of the treatment. See, rivaroxaban is down here, and the number of events of recurrences are up here. That tells us that the number needed to treat to prevent one primary efficacy outcome, this is a recurrence, is 15 patients. This is a busy slide that summarizes practically everything. It says that rivaroxaban has produced an 82% reduction in these cases. The most important thing is that there was an increase in bleeding, 5.4% versus 1%. And now we come to the final study. This is the pulmonary embolism study. Patients who had confirmed symptomatic pulmonary embolism with or without DVT were randomized to receive rivaroxaban from day 1, 15 milligrams for 3 weeks, followed by 20 milligrams for up to 12 months, versus conventional therapy and oxabolate followed by warfarin. And this study, which was published a month ago in New England Journal of Medicine, tells us that rivaroxaban was not inferior to standard therapy, and this statistic is for non-inferiority. In other words, we had exactly the same results. Symptomatic recurrent pulmonary embolism was 2.2%, had a 2.2% recurrence in the rivaroxaban group, and 1.8% incidence in the standard therapy group. This hazard ratio is 1.12, and here are the confidence intervals. Major or clinically relevant bleeding, rivaroxaban 1.1%, standard therapy 2.2%, small percentages, but statistically significant in favor of rivaroxaban. So, having presented to you all the data, I would like to pose a number of questions that are going to keep us busy for the next few years. I would like to know, what's the efficacy of preventing recurrence in patients with cancer? So we need studies in patients with cancer, because as we know, these patients with cancer are the people who need extended therapy. What about the patients who have thrombophilia? Is there a better vein recannulation than warfarin? This is a very important question, because not only we want to prevent recurrence of DVT and pulmonary embolism, but we want to prevent the post-thrombotic syndrome. Now, those of you who, some of you may be aware, we have about 6 randomized controlled trials so far where subcutaneous heparin was given for 3 months versus warfarin. And as you know, low molecular weight heparin works as an anti-10A, and when you look at the phlebograms, there was a better recanalization in those who received low molecular weight heparin for 3 months. If you look at the phase 2 trials of rivaroxaban, as I did, and they looked at the amount of thrombus remaining in the repeat venograms, there was better recanalization. So we are hoping that some of these drugs will prevent the post-thrombotic syndrome. And that answers my question number 3. And then we want to know what is the efficacy in preventing pulmonary hypertension. And finally, having shown that extended duration of prophylaxis is more effective than stopping early, we want to know what is the optimal duration. So those of you who will be reading the papers that will be appearing in the next year or so, keep thinking of these questions. Thank you very much.